Good morning, everyone. Honorable Emeritus Chairman Dr. Swankar sir, Vice Chancellor Dr. Gulati sir, Advisor to the Chairman Dr. Sachdeva sir, respected senior faculty members, colleagues, and dear residents. It's a matter of immense pride and privilege that I stand before each one of you today to present the overview of the Department of Pediatrics of our esteemed institution before the scheduled presentation of its clinical combined round, or CCR as it is popularly known as. So at the Department of Pediatrics, we train future pediatricians to optimize the health and well-being of infants, children and adolescents through education, research, leadership and excellence. That is our vision. The mission encompasses excellent hospital and community-based healthcare, improved teaching methodologies coupled with innovative research and professional growth in relation to pediatrics. We started in this department was established in the year 2000. It is dedicated to holistic pediatric care and teaching. The faculty consists of 4 professors, 4 associates, 9 assistants, 3 senior residents and 27 junior residents. This is the status of our pediatric OPD, which is rising by the year, as we can see an improvement in the OPD cases. As far as the IPD is concerned, yes, we need to improve upon our numbers as we go about. Already we are having a good number as far as the 2025 data up to July is concerned. Keeping in tune with the changing times as well as catering to the diverse needs of our ailing children, we have diversified in form of subspecialties like pediatric intensive care, pediatric nephrology, thalassemia and pediatric bone marrow transplant, pediatric gastroenterology and hepatology, and pediatric neurology. Besides the general pediatric ward, which forms the crux of our services, the pediatric intensive care unit caters to more than 1,000 admissions in a year. We are equipped with the state-of-the-art facilities for diagnostic and therapeutic care to our ailing children. At pediatric nephrology, we are doing 80 to 100 dialysis per month. The latest modalities like SLED, CRRT, and plasma exchange are available to manage our renal issues in our children, thanks to the facilities provided by the management. In total, 5,000 such procedures have been performed till date. At thalassemia and pediatric bone marrow transplant, we have conducted 221 bone marrow transplants till date, and with facilities of free HLA typing. And we are the first medical college in Rajasthan to provide hands-on training to pediatric residents in bone marrow transplant. As far as pediatric gastroenterology and hepatology is concerned, we are doing upper GI and lower GI procedures to the tune of 352 in the last 3 years. At pediatric neurology, we are dealing with all major neurological disorders with specialization in complex epilepsy care, close to 1,200 cases per year. With among them, 42 children were such which were diagnosed as non-epileptic event and were fed of all the medicines that they were being initiated earlier on. We have facilities for video EEG monitoring, and we have in-house MRI and PET scan to help us in the process. We have 38 epilepsy surgeries have been performed with remission observed, complete remission observed in 70% of our patients. At Child Development Center, we are diagnosing and providing therapeutic in specific learning disorders. Our UG and PG teaching program is robust, where we have implemented CBME since admission batch 2019. Our post-graduation commenced in the year 2009 with 58 postgraduates trained so far. Our faculty is very much into training at Skill Lab, where we are imparting training in form of advanced NRP courses, basic NRP courses, ACLS courses on a regular basis. Recently we had an advanced NRP course on 3rd of August only, where we trained 35 postgraduates in the art of neonatal resuscitation. We have published 52 publications in renowned national and international journals in the last 5 years. We have been blessed with faculties from Italy, that is Dr. Lawrence Faulkner, who deliberated on cost, quality assurance and outcomes in bone marrow transplantation for thalassemia on International Thalassemia Day. We had Dr. Shipra Gupta. He is a renowned intensivist from Lady Hardinge Medical College, New Delhi, to present his deliberation on errors in the initiation of management of respiratory failure in our department. In the heart of the city, it's an upcoming and very promising facility, health facility for children is coming up in the form of MG Children's Hospital, which has served over 10,000 children through OPD, IPD in last 2 years. We are equipped with state-of-art NICU and PICU facilities at MGCH, and recently we have initiated pediatric subspecialty OPDs over there. In November 2024, we organized international conference on birth defects. This was attended by more than 300 delegates. On International Thalassemia Day, which was celebrated on 8th May 2025, recently bone marrow transplanted 50 children along with their parents were invited and were presented with gifts from the dignitaries, as well as philanthropists were felicitated on this occasion. Subsequently, on 9th and 10th of May, Thalcon 2025 was organized, which was the first conference solely on thalassemia, which was attended by close to 300 national and international delegates, and a hands-on workshop on transfusion practices was attended by 35 delegates. We have an upcoming conference on in the month of November 2025 on pediatric nephrology. We invite all of you to join us in this academic feast. As part of social initiatives, we have been regularly organizing school health camps and outreach camps by the faculty of the department, so that to boost our OPD and IPD. Whether it be the community or any hospital ward or even the hospital lobby, our faculty has put forward its efforts to educate the community as far as common health issues are concerned. We are in the midst of a World Breastfeeding Week, which we celebrate every year in conjunction with the Department of Neonatology, where we not only teach and train our mothers who have just delivered, but we also conduct quizzes and panel discussion to educate our PGs as well as the other fellow colleagues. We have a panel discussion today also in this Dhanvantri Hall at 2 p.m. on breastfeeding. Owing to our services, we have been felicitated. Some of us, say for example, Dr. Sanjay Khatri, Dr. Satyan and Dr. Ajay Goenka were recently felicitated by IAP Jaipur for outstanding contribution to services. As part of our future plans, we intend to consolidate our departmental services so as to improve upon them. We need to expand our subspecialty services. We intend to have a robust immunization policy which enables availability of all vaccines in MGH as under UIP. We intend to commence fellowship and DM programs in pediatric critical care, nephrology, bone marrow transplant, pediatric gastroenterology and neurology, and we have our eyes on research and publications and pediatric oncology at the same time. With the blessings of the Almighty, as well as my elderly parents and the vision and support of the management, I sincerely hope to carry forward the department and develop it in the best possible way in the times ahead. Thank you. May I now invite Dr. Nishtha Gupta, our third year junior resident, to present the CCR for the day.
Thank you, sir. Good morning, Emeritus Chairperson, sir, respected faculty members and my dear colleagues. Today we are presenting a CCR for a child aged 4.5 years with abnormal body movements. So the child came to us with complaints of abnormal body movements since the age of 6 months. He also had delay in speech acquisition since late infancy. These abnormal body movements were first noticed at the age of 6 months. As discussed, there were multiple seizure types, including rhythmic jerky movements involving all 4 limbs and sudden drop attacks. These episodes were 10 to 20 episodes per day, each lasting from few seconds to few minutes. These were unprovoked, not associated with any involuntary passage of urine or stool, and were occasionally associated with post-ictal dullness and drowsiness. Here there is a video of the patient which is taken in our hospital recording one such episode. Here we can see that the seizure is preceded by aura, and by looking at the episode we can say that it is indicating more towards a behavioral problem rather than a seizure. So that was the reason for detecting these episodes late outside. He also had delay in speech acquisition since late infancy. Here I would like to emphasize that normally by the age of 6 months a child starts babbling, and by the age of 1 month a child starts speaking bisyllables. But our patient, he started speaking bisyllables by the age of 2 years. And only recently he's been able to put 2-3 words together but cannot form meaningful sentences. Also there is limited social interactability. He only uses certain hand gestures to tell his needs to his parents. There was no hearing difficulty as per parents. Prior to the onset of these complaints, there was no history of head trauma, fever. There was no altered sensorium noticed by the attendants. There was no any previous hospitalization due to any cause, although they took various OPD-based consultation for the seizure episodes, and anti-epileptics were also advised. No sleep disturbance or regression in development was noted. The antenatal, natal and postnatal period was uneventful. The child was born by a normal vaginal delivery and his birth weight was normal, which was 2.7 kgs. There was no history of an ICU stay or any hospitalization till 6 months of age. On detailed developmental examination of the patient, we did this in 4 domains. First of all, in gross motor domain, he could ride tricycle, which is consistent with 3 years of age. He could climb stairs alternatively and hop on 1 foot, which is consistent with the current age of the patient. He could copy circle and cross, which is again consistent with his current age. So there was no delay in gross motor or fine motor development for the patient. He could feed himself with spoon and remove his clothes on his own, but he was yet not toilet trained, which is consistent with only 2 years of age. So there was significant delay in social domain. He could speak 1 to 2 meaningful words but cannot put these words to form a complete sentence, which is again consistent with only 1 year of age. So there was a significant delay in language domain as well. So we calculate a developmental quotient, which is a ratio of developmental age divided by the chronological age of the patient. Normally it should be 1. If it is less than 1, it indicates a delay in the development. Here we can see that there is significant delay in social and language domain, and overall developmental quotient is 0.6. The child was immunized till date and there was no significant calorie or protein deficit in intake. He was born out of non-consanguineous marriage. He is a single male child and there is no history of any similar complaints in his family. According to modified Kuppuswamy score, the family belonged to a lower middle class status with the score being 13. So on taking detailed drug history, we found out that when the child was 6 months of age, the parents noticed head drops, for which on OPD based consultation he was advised valproate. Then after 2 months, when these head drops did not improve, one more anti-epileptic, vigabatrin, was added. Then after 1 year, he started experiencing myoclonic jerks, for which again one more anti-epileptic, clobazam, was added on OPD basis. Then after 1 year, the child started experiencing generalized tonic-clonic seizures, for which levetiracetam was added. And then finally, when the child came to us, he was having generalized tonic-clonic seizures and was already on 5 anti-epileptics. Despite of these anti-epileptics, he was still having 10 to 20 episodes per day. So to summarize till now on detailed history, we have a 4.5 years old male child who is born out of a non-consanguineous marriage belonging to lower middle class status with normal birth history. He came to us with complaints of abnormal body movements, including multiple seizure types, which were refractory to 5 anti-epileptics and was often associated with dullness and confusion. There was significant delay in the speech and social development of the patient. So on the basis of this history, I would like to ask from the audience what can be the clinical possibilities which comes to our mind. So there can be many possibilities which are characterized by multiple seizure types refractory to anti-epileptics along with developmental delay. We can categorize them in various domains. First one is genetic, which include various syndromes as said by my colleague, Dravet syndrome. There can be brain malformations as listed here. There can be any inborn errors of metabolism. There can be even chromosomal anomalies like Fragile X syndrome, any congenital infections like TORCH, or any neurocutaneous disorders. So to further get a clear picture, we did a detailed general examination of the patient. The child was lying comfortably. He was awake and oriented, but he was interacting minimally, even with the parents. He appears to be adequately built and nourished. All the vital parameters were within normal range for his age. On detailed anthropometric assessment, which we did, included weight, height and head circumference. Here we saw that according to the WHO IAP growth chart, where we can see that our child's weight for age here lies on the blue line, which signifies between 25th centile and 50th centile, which is normal for his age. Normally it should be above this pink line. Now this is a WHO IAP growth chart where the height is plotted against the age in months. Here also we can see that it lies between the 10th and 25th centile. The height for age should be above this green line, which signifies 3rd centile. So again, this is normal for our patient. Now the height is plotted against, the weight is plotted against the height, and here again it is within normal parameters between 50th and 75th percentile. Now I would like to emphasize on the head circumference for age. Again here it is between 50th and 75th percentile, which signifies normal brain growth of the patient till now. On head to toe examination, there was no abnormality in the shape and size of the head. The eyes were normal. There was no evidence of any facial dysmorphism. No extremities, there was no abnormality in the extremities. No skeletal deformity and no skin lesions were observed. Here I would like to show some specific cutaneous lesions which we saw in our patient, like these ash leaf macules we can see here, cafe-au-lait macules, cutaneous neurofibromas, Chagreen patch and port wine stain. All these lesions were absent in our patient. Now, as by the history, we know that the possible etiology is from the central nervous system, so the examination of the same was done first. The patient was awake and alert. He could follow commands. He could tell his name. Although the higher mental function assessment was limited due to his age and developmental delay of the patient, there was no abnormality detected in cranial nerves examination. The motor system examination was done in all the limbs. It was normal, including the deep tendon reflexes and superficial reflexes. The sensory system was intact. There were no cerebellar or meningeal signs. So here we can say that the central nervous system examination was normal. Only there was developmental delay and there was limited social interactability. Other systemic examination, including cardiovascular system, respiratory system and para-abdominal, it was normal. There was no abnormality detected. So in a child who comes to us with seizures, we normally only focus on the seizures and its numbers only. But it is important to know its impact on the quality of life. So to assess that, we use two scales. The first one is Global Assessment of the Severity of Epilepsy Scale. So this is a 7-point questionnaire which is filled by the physician, and each of these points are graded from 1 to 7. 1 indicating not at all severe and 7 indicating extremely severe. Here we can see by this scoring system. In our patient, in all these scores, it was either 5 or above, which indicates the severe nature of the disease, and the total score was 39. So there is a cutoff for 30. Above 30, it indicates the severe impairment in the quality of life. This is one more questionnaire, Quality of Life in Childhood Epilepsy questionnaire. It is a 2-point questionnaire which is filled by the parents. Here we can see that the total score was 2. Each of these points are categorized from 1 to 5. 1 indicating poor quality of life and 5 indicating excellent. And here the total score is 2. By this reference scale, we can see that this score signifies very poor quality of life. So, for a quick recap till now, we have a 4.5 years old male child who came to us with seizure abnormal body movements is 6 months of age, which are refractory to 5 anti-epileptics. There was significant delay in speech and language development of the patient. Systemic examination was normal, including central nervous system examination, and there was severe impairment and neuropsychological assessment leading to poor quality of life. To get a clear picture, we requested various lab values. The complete hemogram was done. There was no significant abnormality observed. The inflammatory and sepsis markers were done, which were normal. Baseline renal functions and liver function tests were also within normal range. As we know that the patient came to us with developmental delay, so to rule out hypothyroidism, we did thyroid function tests, which were normal. All the electrolytes value were within normal range. We already stated that we are considering metabolic disorders as one of our differentials. So to rule out that, we requested gas chromatography mass spectrometry and tandem mass spectrometry, which is normal, and a baseline arterial blood gas of the patient was done, which reported no such anomaly. To rule out any cardiac defects, 2D echo was done, which was normal. We already stated that there can be a possibility of any congenital infections for which torch profile was sent, which came out to be negative. A screening sonography of whole abdomen did not relieve any anomaly. And to rule out any chromosomal abnormality, we requested karyotyping for the patient, which was again reported to be normal. As the patient came to us with speech delay, so for that a hearing assessment was done, which was normal. The hearing of the patient was normal. Here I am showing a video EEG of the patient. On the left side we can see the video of the patient, and on the right side there is EEG. Here I would like to emphasize that the red waves here signifies the waves coming from the right side of the brain, and the blue waves here comes from the left side of the brain. Here as we can see that now the seizures are starting, which are originating from the right frontal region. Later on it is getting generalized to all the regions of the brain. So after this we can say that the seizures are of focal onset originating from the right frontal region of the brain. So according to International League Against Epilepsy 2017 classification of seizure types, we can classify the seizures for our patient as focal onset with impaired awareness. So all the things which we already know, we could add one more thing, that the seizures were of focal onset with impaired awareness originating from the right frontal region. So after this detailed investigations, examination and history, we could rule out certain differentials which we listed previously. So as the torch profile was negative, the infective etiology was also ruled out. Karyotyping was reported to be normal, and there was no finding in the physical examination of the patient also, so chromosomal anomalies were ruled out. As we already saw that GCMS, TMS, mass spectrometry was normal, so inborn errors of metabolism are also ruled out. There were no specific cutaneous lesions observed on the general examination, so neurocutaneous disorders are also less likely. Now we are left with genetic and brain malformations. So to get a clear picture, we requested certain brain imaging. So to discuss about the MRI findings, I would like to request Dr. Shlok Singhal from the Department of Radiodiagnosis to explain about the MRI.
Good morning, respected teachers, seniors and my fellow colleagues. Today, myself, Dr. Shlok Singhal, a first-year radiology resident, is primarily here to discuss the MRI findings of the case. This case was referred to the Department of Radiodiagnosis with the clinical history of a 4.5-year-old male child with refractory seizures, developmental delay and focal onset with impaired awareness primarily in the right frontal region and severe impairment of quality of life. MRI brain was advised as it is much more sensitive in depicting parenchymal abnormalities. It was performed under anesthesia. T1 and T2 sequences were normal, and since FLAIR sequences, that is fluid attenuated inversion recovery sequences, are the best to describe these type of lesions, henceforth we have used these images. This is a coronal FLAIR view showing multiple hyper intense linear wedge shaped hyperintensities extending from the lateral ventricles up till the subcortical margin. What I exactly mean by a hyperintense signal or hyperintensities is that something which is bright as compared to the underlying white matter. We call these as white matter radial hyperintensities. This is another image showing multiple radial white matter hyperintensities. This is an axial T1 weighted image of the same case showing nodular bumps protruding from the walls of the lateral ventricle from the anterior horn in the first image and from the occipital horn in the second image. These lesions are classically called as subependymal nodules and are generally less than 1.3 centimeter. This is another coronal flare image showing hyperintense signal as compared to the normal contralateral side at the level of temporal lobe and posterior to it. These lesions are classically called as cortical tubers and basically broad and expanded gyres. Clinical history along with MRI findings of cortical tubers, radial white matter hyperintensities and subependymal nodules were suggestive of tuberous sclerosis complex. Other radiological differentials to be considered were focal cortical dysplasia, which are generally solitary. On the other hand, tubers are generally multiple. And if it were to be a focal cortical dysplasia, but with the existence of so many of these lesions, it is likely to be associated with tuberous sclerosis complex. Other DD could be grey matter heterotropia. In grey matter heterotropia, the subependymal nodules are generally iso-intense to the grey matter. Henceforth, we have ruled this out. Thank you so much. Now I would like to invite Dr. Nishtha Gupta to continue the case forward.
Thank you, Dr. Shlok. So as we saw from the MRI findings that now we are left with one probable diagnosis, which is tuberous sclerosis complex. So before moving forward, I would like to speak some points about tuberous sclerosis complex. So this is a rare disorder with autosomal dominant inheritance. The mutations found here is in TSC1 and TSC2 gene. So this complex is characterized by multiple hematomas found in various organs, including brain, kidney, heart, and other organs. Clinically, the patient has neurological and psychiatric domains affected, including intellectual disability, and 90% of the patients develop seizures. Out of these, 50% or more patients have seizures which are refractory to standard anti-epileptic drugs, as we also saw in our patient. So according to the updated 2021 International Tuberous Sclerosis Complex Consensus, there is a diagnostic criteria for the same, which includes one clinical criteria and one genetic criteria. So first I will discuss the clinical criteria. In this, there are 11 major criteria points. In our patient, the two of the major criteria points were met as indicated by MRI findings. There were multiple cortical tubers and subependymal nodules. None of the minor criteria points were found in our child. And there is a genetic criteria which states that identification of either TSC1 or TSC2 pathogenic mutations in the normal tissue is sufficient to make a definite diagnosis. So according to these guidelines, a definite diagnosis can be made when there is either genetic criteria fulfilled or two major criteria is present, or one major and two or more minor criteria are present. In our patient, we have already met with two major criteria, but as the patient has some atypical presentation, there were no specific cutaneous lesions which were normally found in neurocutaneous disorders, and also to rule out other genetic disorders which we already stated, we requested a whole exome sequencing of the patient, which again revealed the same. There was mutation found in TSC1 gene, confirming our diagnosis. So a final diagnosis of tuberous sclerosis complex can be made. To discuss the overview and management part of this disease, I would like to invite Dr. Shipra Majumdar from the Department of Pediatrics to take the case forward.
Thank you so much. Good morning, everyone. So as we had discussed earlier, that tuberous sclerosis is a rare genetic condition, and we are moving towards targeted therapies for this. So what do we mean by targeted therapies? Targeted therapies are those therapies that act on the enzyme complex from where the disease originates. So here is the etiopathogenesis before we move towards the targeted therapy, which describes that certain growth factors and hormones, they come and attach on the neuronal intracellular membrane in the mTOR pathway, which activates the TSC1 and TSC2 complex. So in case of a genetic mutation in either of the genes of TSC1 or TSC2, there is an overactivation of the mTOR pathway here, which leads to increased protein synthesis, cell proliferation and growth, leading to hematoma formation in various organs. And with targeted therapy, what we are aiming is that we want to inhibit this mTOR overactivation, and we can achieve that by use of everolimus, thus leading to decreased formation of hematoma and stabilization of already formed subependymal giant cell astrocytomas. So the unique thing with this targeted therapy is that we are actually targeting the root cause of the disease rather than just treating the symptoms. As we had already known that our patient was on multiple anti-seizure medications, and with the definite diagnosis of tuberous sclerosis on the genetic study, we were able to start the patient on targeted therapy with everolimus at a dose of 10 milligram per deciliter of trough serum levels. So it was a high dose therapy that we used in our patient, and with that we were able to see that earlier our patient was having almost 10 to 20 seizures in a day, and that reduced to 10 to 20 seizures in a week. There was significant seizure reduction, and with start of everolimus we were also able to reduce the number of medications, anti-seizure medications, from 5 to 2 medications. But there was no significant, but our main goal was to achieve seizure control, a complete seizure remission, which we were not able to achieve. Could that be because we had started the therapy late in the course of disease, and if we had started earlier, the patient might have been in seizure remission by now. So now we are here with decreased seizure frequency and decreased anti-seizure medications, but our goal of seizure freedom is not achieved. So to work up with that, we have to think about something else. We have to go to the next level of management to find out the source of seizures, and that is from which part of the brain they are coming from. So in our patient, the clinical symptoms, the EEG findings and the imaging study was corroborative that the seizure was originating from the right frontal region of the brain. And how does it help us? It helps us in deciding the further course of management. We know that the success with addition of any new drug is less than 5% in seizure control. The success rate with ketogenic or modified Atkins diet, that too on a lifetime dietary modification, is 10 to 15%. But then we have resective surgeries, especially lobectomy in our case, that provides a success of up to 70%. So with this high success rate of up to 70%, we decided to go for a neurosurgical opinion for evaluation whether our patient was a candidate for resective or curative surgeries. So to discuss the neurosurgical evaluation, I would like to call upon Dr. Anmol Anant Dobriyal.
Thank you, Shipra. Good morning, everyone. Now, moving with the case forward, we were presented with a 4.5-year male child who presented with focal seizures and impaired awareness, and the seizure was localizing on video EEG on the right frontal lobe. He had severe impairment in quality of life as discussed in the scales previously, and was on medical management since 5 months and having no significant seizure control. Mainly the epilepsy surgeries are of two types. They can be classified as palliative and curative. The palliative surgeries are usually done in patients in which there are multiple seizure foci, and we cannot achieve a complete seizure freedom, but we can provide decrease in seizure frequency and improve the quality of life. And in curative surgeries, there is a definitive lesion or part of the brain which can be resected. So the curative surgeries are divided into the lesionary section, the lobectomies or corticectomy, and the goal of the curative surgery is that he can lead a normal life and preferably off anti-epileptic medications and become seizure free at a younger age. So in our patient, the curative surgery was decided. Then why frontal lobectomy? Because tuberous sclerosis has multiple tubers and it is like a tree root like pattern,
and there is not a single seizure foci, but on video EEG it was localized in the right frontal lobe. So frontal lobectomy was chosen as a surgical procedure, and after explaining the pros and cons of the surgery and taking proper consent from the parents, the surgery was planned. The incision for the surgery is a bicoronal incision. The patient is laid supine with chin lightly tucked, and after giving the incision, the myocutaneous flaps is raised and the right frontal craniotomy has been done. A brief video of the surgery. This is the anterior part, the posterior part, this superior frontal gyrus, the middle frontal gyrus, and the inferior frontal gyrus. All these gyruses are removed. This is the medial part. Now the resection is being done on the lateral part, and the lateral cortical resection is being done. And then moving on to the medial part. This is the falx, and medially the lobe has been retracted, and the resection is being continued on the medial part. Then this is the anterior pole of the frontal lobe. This again is the medial part. We go from lateral to medial and slowly move towards the resection of the whole lobe. Now this is the whole lobe is being removed here, and this is the whole lobe, and this now this is the final part. The lobe has been removed. We can see this is the falx. This is the anterior part, the posterior part, and the remaining part of the frontal lobe is being removed from above the corpus callosum. Now the post-operative course. The surgery was uneventful, and the excised specimen was sent for histopathological examination.
Can I ask a question?
Yes.
Do you have to remove the frontal lobe? If you cut the connections of the frontal lobe, is it as effective?
There is a procedure called lobotomy.
Yeah.
Lobotomy.
Which only divide the connections and not excise the lobe. That's still practiced?
Sir, we want to the seizure was originating from the right frontal lobe, but there is no particular lesion that we can identify. So there are multiple lesions suspected. So we go for a whole lobe resection so that the seizure freedom can be achieved, sir.
So like if you cut the connections of the frontal lobe and
yes.
not physically remove the lobe, will that not be as effective as removing the lobe?
The seizures can be, sir, generalized from other parts because we.
So if they are from the other parts of the brain, then they are there. Then the frontal lobe removal.
So the success rate for lobectomies is very low, sir. Previously we used to do it. But if you have let's say we have a whole temporal, parietal, occipital, very big areas, then we go for the disconnective surgery, sir. But if you have a localized lesion, the chances of success is much higher. Lobectomy success rate is 40%. Lobotomy, sir. But for lobectomies, it can go up to 70%, sir. So that's why we choose for a localized lesion, always better to remove it. If it's a big lesions, multiple lobes, we always go for disconnective surgery, sir.
Then the patient was shifted to the pediatric ICU post-operatively. NCCT head was done 4 hours post-operatively. There was no collection seen. The patient was extubated after 24 hours post-operatively, and there was no neurological deficits. Now I would like to invite Dr. Prakrati from Department of Pathology.
Myself, Dr. Prakrati, and I will be discussing about the histopathological examination. A 4.5-year-old male child presented with intractable seizures not completely resolved by conservative management. He underwent a frontal lobectomy by the neurosurgery department. We received the resected frontal lobe specimen for histopathological evaluation. On gross examination, the formalin-fixed specimen consisted of 2 gray white soft tissue pieces, one measuring 8 into 5 into 3.5 cm and other measuring 3.2 into 2.5 into 1 cm. At low power, image A shows both the areas, the characteristic string of pulse appearance, which is formed by vertically aligned neurons, as well as dysmorphic neurons and few balloon cells in the background. In image B, we can see the string of pulse pattern more clearly. In image C, on high power, we get a magnified view of the dysmorphic neurons and balloon cells. So based on the microscopic findings, the diagnosis is made as focal cortical dysplasia type 2B, which is known to be associated with tuberous sclerosis complex. Now may I please invite Dr. Nishtha to take the case forward.
Thank you, Dr. Prakrati. So we received the patient from the neurosurgery department in a vitally stable condition, post-frontal lobectomy. Now, as we already discussed, that when the patient came to us, he was already on 5 antiepileptics. After introduction of everolimus, the antiepileptics could be narrowed down to 2. We gave everolimus for 5 months, but as complete seizure remission could not be achieved, we went for the surgical intervention. And post-surgery till now, the patient has been completely seizure-free and is currently on only 1 antiepileptic, which is levetiracetam, and everolimus is being continued. So we already saw that the global assessment of the severity of epilepsy scale was done previously when the child came to us. Now we did this again on follow-up after 8 weeks of the surgery. Here we can see that there is significant improvement in the score, leading to a good quality of life now. Now to discuss the review of literature related to our case, I would like to invite Dr. Shipra to discuss the same.
Thank you so much, Dr. Nishtha. So as we discussed earlier, the tuberous sclerosis complex is a rare disorder, and we thought of targeted therapies that work in the mTOR pathway. The reason we used it in our patient is because of this EXIST-3 trial, which evaluates the efficacy and safety of everolimus in tuberous sclerosis-related refractory epilepsy. We had 366 patients aged more than equal to 2 years. It was a randomized double-blind placebo-controlled phase trial, and we could see a really good outcome with more than 50% seizure reduction in almost 68% patients who received everolimus. Which corroborates well with our case also, where we gave high dose everolimus and there was 50 to 60% seizure reduction in our patient also, and it was tolerated very well. So the next question arises whether we should have started it earlier. Could it have been beneficial for a patient? So to support that, we have various studies stating that starting it earlier could have been even better. Not just it would have controlled the seizure and tumor reduction, but it also would have helped in the long-term prognosis. Firstly, with the prevention of the subependymal giant cell astrocytoma formation and reducing and stabilizing the already existing subependymal giant cell astrocytomas. And secondly, by significantly improving the cognitive and neuropsychiatric outcomes. In cases, there is a growing trend that we should start it as early as possible, that we were missing in our case. And cases which do not respond to the medications, we have to go to the next step of management, which was surgery that we did in our patient. So here is the 2024 meta-analysis on epilepsy surgery outcomes in children with tuberous sclerosis complex. And it is a huge trial. It comprised of 44 studies with almost 2,000 patients, and the surgical outcome showed that overall 66% patients had a good surgical outcome, good seizure control, as we also had in our patient. So we corroborated with the recent literature, the use of everolimus, and we followed up with a surgical opinion in our patient. So now I would like to call upon Dr. Ajay Goenka, sir.
Good morning, everyone. So thanks a lot, everyone. So this was a very good case, sir. So from achieving like 10 to 20 seizures a day, we were able to reduce it to 10 to 20 seizures a week, and then complete seizure freedom, sir. So I saw him yesterday only, actually. So for lack of better words, sir, he was actually looking like a kid, sir. जब भी मेरे पास आता था ऐसा नशे में झूमता बस आता था, चिड़चिड़ा होता था. कल पहली बार बदमाशी कर रहा था, खेल रहा था, ऐसा लग रहा था कि एक 5 साल का बच्चा आया है आपके पास में. So it was really like important to see that these things make such a big difference. So small.
क्योंकि 7.5 साल का है, इसे स्टार्टिंग से ही एपिलेप्सी की समस्या थी. दिन में 4-5 बार से दौरे आते थे. मैंने इसे बहुत जगह दिखाया, लेकिन कोई फायदा नहीं हो रहा था. तो मैंने इसे अजय गोयनका सबको दिखाना चालू किया. अभी कुछ काम पहले उन्होंने मुझे सर्जरी की सलाह दी, जो कि महात्मा हॉस्पिटल के डॉक्टर Dept शर्मा सत्य द्वारा उन्होंने कराने की मुझे सलाह दी. मैंने उनकी सलाह को मानते हुए 31 मई को सर से महात्मा जो कि सफल रही, तब से लेकर आज तक इसे कोई समस्या नहीं है। मैं डॉक्टर जगवंत सरकार और डॉक्टर
So the reason we choose this case is because there's a need for targeted therapy, sir. Just ये नहीं कि seizure है तो sodium valproate दे दो, medicines दे दी. The need is to find the reason क्यों है seizure, and we have to do the either medically or surgically we have to cure them, sir. As we discussed, 38 epilepsy surgeries in last 1.5 years. 70% of patients are completely seizure free, sir. They were having multiple medication, 5-6 medications चल रही थी, seizures चल रहे थे, and now they are completely free. So take home point is like if you see a patient, please think if they are requiring more than 2 medicines, please think of pre-surgical workup. It's very safe and rewarding in long term, reducing the medicines, controlling the seizures. And what these kids need is not just focus on seizures. We have to look at their academic profile, social interaction, development also. So we have started a small learning disability center in our department, try to help this kid, and hopefully in the future we will elaborate it further. There's a huge need, sir. Kids with autism, kids with ADHD, learning problems, there's a very big need in Rajasthan to help these kids, sir. There's less understanding about autism. We talk about a lot, but the treatment is very limited, sir. So we really need a very comprehensive center to help these kids, sir.